We're going to speak today about clinical management of long COVID. So long COVID was first noted in this publication back in July 23rd of 2020 when Dr. Paul Gardner, a professor of epidemiology at the London School of Tropical Medicine, wrote, I'm unable to get out of bed for more than 3 hours at a stretch. My arms and legs are permanently fizzle as if injected with Szechuan peppers. I have ringing in my ears, intermittent brain fog, palpitations, and dramatic mood swings. Subsequently, Ed Young in The Atlantic described as long haulers. And then we started seeing this as the mystery was happening with many people having the syndrome and many people not understanding what was going on. Now, as you recall, early in the pandemic, a lot of the patients were in the ICU, and we need to remind ourselves that many survivorship in the ICU are things that we have seen in the past. We have seen joint contractures, we can see diaphragmatic dysfunction, laryngeal injury, impairments of memory. And in fact, my ICU colleagues pointed me to this article about long-term cognitive impairment after critical illness. This is before COVID. This was published in 2013, and clearly shows that people that spend a lot of time in the ICU have significant cognitive impairment after they recover. But one of the things that we were needed in long COVID is a definition. So until recently, there was no consensus definition and also no consensus name. We call it long COVID, we call it long haulers. Now that the preferred term is post-acute sequela of SARS-CoV-2 infection, or PASC. So post-acute COVID is when somebody has symptoms extending beyond 3 weeks after initial symptoms, and chronic COVID or PASC is when somebody has symptoms beyond 12 weeks. And we've seen definitions both by CDC and more importantly by WHO. WHO defines long COVID as a condition that occurs in individuals with a history of probable confirmed COVID, usually 3 months from the onset of COVID, with symptoms that last for at least 2 months and cannot be explained by an alternative diagnosis. In the COVID symptom study, we have seen this data coming from multiple countries, multiple millions of people, and it suggests that probably 10 to 15% of individuals with COVID, even in mild cases, do not recover quickly. This was a study from in the United States, a telephone survey done by CDC and people that had outpatient COVID, and 1 in 5 had not recovered rapidly. And in fact, many of them continued to have symptoms and did not return to the usual state of health. And then this meta-analysis from multiple countries shows who has developed the symptoms of post-acute sequela of COVID. And you can see, depending whether they're hospitalized or non-hospitalized, you can see where the numbers are, but roughly around 30%, 45% of people seem to have this syndrome. So this suggests that, even in adults that don't require hospitalizations, 2 out of 3 at least have one symptom within in the first 1 to 6 months after their diagnosis of COVID. And the most common symptoms are chest pain or throat pain, shortness of breath, fatigue, and cough. This study in the Netherlands suggested that 21% have persistent symptoms compared to those in the control group. And the excess in those symptoms are, again, chest pain, difficulty breathing, painful muscles, general tiredness, and headache. And suggests also that about 12 to 13% of 1 in 8 people who consider to develop this condition. So what do we know about pathogenesis? Well, there's a lot of pathogenesis thinking that maybe this is reactivation of herpes virus, such as EBV or VCV. There could be multiple antibody plus cellular immune markers consistent with high immune system activation. And there are levels of cortisol that are uniformly low in patients with long COVID. But a fairly recently published study from the NIH did not found evidence of persistent viral infection, autoimmunity, or abnormal immune activation. So what are the symptoms that we're going to see in individuals with COVID? Well, post-COVID, you will see after the exposure, the patients are no longer PCR negative, but fatigue, decrease in quality of life, muscle weakness, joint pain, dyspnea, cough, persistent oxygen requirements, anxiety, depression, sleep disturbances, PTSD, cognitive disturbances, headache, palpitations, chest pain, thromboembolism, kidney injury, and hair loss are the most common symptoms. This is an Italian study that found after people had had COVID and had been hospitalized, the most common symptoms were fatigue, dyspnea, joint pain, and chest pain. And although 12% of patients did not have any symptoms, fully 55% of them had at least 3 of the symptoms after they had recovered. And it's a study that was done in healthcare workers, again, suggesting that many individuals continue to have symptoms. And in fact, 15% report at least one moderate symptom lasting more than 8 months, and 12% reported symptoms that cause disruption in home life or work life. There's been a lot of question whether children and adolescents get long COVID, and this study suggests clearly that they do, and they could have also the similar complications. So what is a clinical evaluation? Well, I think it's very important that the clinical evaluation considers, a good history, physical exam. It's usually done 4 to 6 weeks and up to 12 weeks after discharge from COVID, after recovery from COVID. And we need to look for, signs of respiratory manifestations, neuropsychiatric manifestations, renal manifestations, cardiovascular manifestations, and look for hematology, look for thromboembolism and those risks. And where is this best done? Well, it's best done in primary care. And then after recovery, it's important to consider early rehabilitation, patient education. And I think it's very important to consider enrollment in clinical research studies because those are going to be critically important. So what are the manifestations? Well, the cardiac manifestations include myocarditis and ventricular arrhythmias. These are probably due to direct invasion of the virus, but also to inflammation. We know that the virus causes blunting of ACE2 receptors. And the question really is, are we going to see an increase in heart failure over time as a result of COVID? And we can see from this article in Science that this damage to the myocardium, it may in fact cause necrosis, cardiogenic shock, and multiple other complications. So it could be almost like the patients had an actual infarction. In this study from an autopsy study in Germany, in 39 consecutive autopsies, they found evidence of viral infection in the heart in a significant number of their patients. Pulmonary manifestations include a cough, fibrotic lung disease, bronchiectasis, and pulmonary vascular disease. This is due to inflammation in the lung. When it inflames, it produces fibrosis, thromboembolic disease. And the question is, are we going to see an increase in COPD? Are we going to increase in pulmonary fibrosis as a result? And in many transplant programs and any lung transplant programs, now the number one cause of lung transplantation is actually post-COVID. Neuropsychiatric manifestations include headache, dizziness, trouble concentrating, confusion, hallucinations, and stroke. This is due to inflammation, could be to direct invasion of the brain. It could be due to hypoxia. And the long-term consequences is really this COVID brain, or this brain fog that we can see in many individuals who say, I'm unable to concentrate in my job. And if you look at the study, this is a fairly large study on people who had recovered from COVID, and you can see using an EHR, they found in patients diagnosed with COVID, many of them had not recovered and had neurological or neuropsychiatric manifestations in up to, between 12 and 33% of them. And this tended to be more common in people who had severe COVID. We can also see renal manifestations such as renal failure and proteinuria, probably from direct invasion of the virus, inflammation, and hypoxia and thromboembolic microangiopathy. And the question here is, are we going to see an increase in chronic renal failure cases and dialysis as a result of COVID? Other organs that could be infected include the GI tract. We can see COVID affecting the bones. We can see COVID affecting the endocrine system and COVID affecting the skin. One of the interesting associations is with diabetes. We know that diabetes is associated with an increased risk of severe COVID, but we have seen now new-onset DKA, including new-onset diabetes, including DKA and hyperosmolar coma in patients who have recovered from COVID. And this may be to the fact that there are ACE2 receptors in the pancreas. And one of the questions is whether COVID is going to be diabetogenic, where we're going to see an increase in diabetes. And in fact, there's something called the COVID Diet Project that is now beginning to look at patients who have recovered from COVID to see if they develop these complications or not. An important question that comes up is do vaccines protect from long COVID? And you can see in this graph, in blue, the unvaccinated individuals, in sort of magenta, those that are vaccinated with 2 doses, in grays, those vaccinated with 1 dose, and in light, purple, those that have been unvaccinated. And you can see here that the kind of symptoms that you develop post-COVID, have fatigue, headache, weakness, muscle pain. And you can see those that have been unvaccinated or have only received 1 dose, tend to have more of those symptoms than those that have received 2 doses compared to those that have been uninfected. So if you look at those that have received 2 doses in magenta, they clearly have less of a manifestation after COVID. So in fact, the prevailing knowledge right now is that if you have recovered from COVID, even if you get vaccinated then right after COVID, you're 7 to 10 times less likely to report 2 or more symptoms of COVID. And unvaccinated patients who receive their first dose within 4 weeks are less likely to then develop long COVID. So it's very important that we think about long COVID. Vaccines protect you from long COVID, but also if you haven't been vaccinated and you get COVID, vaccination can still help you avoid severe complications of long COVID. And more data is needed to understand the relationship. There are many potential treatments that have been looked at for COVID. There's a lot of treatments that are still unproven, but there's at least 26 randomized trials now beginning to take place, trying to test multiple therapies for COVID. And they are in different phases. Most of them are now phase 2 or phase 3. And this include anti-inflammatory agents, cell-based therapies, antithrombotic therapies, dietary supplements, corticosteroids, and other therapies. So I think we need to look at a very organized way into looking at these patients to see if we can indeed find something that helps these individuals with COVID. Now, in October of 2020, I wrote this piece in JAMA about the long-term health consequences of COVID and called attention to the fact that long-ranging longitudinal studies and clinical trials will be critical to elucidate the health consequences of COVID and to compare to other serious illnesses. Because the problem is right now, the way we have been collecting data, the way we have been reporting data, it's clearly biased. We are not having a well-controlled cohort that we can follow and we can understand. And they're being developed, but I think it's really important that we start to understand how you really collect the data, how you look at it, and how you really don't skew the data towards older, more sicker, unvaccinated, hospitalized individuals. So the NIH has responded. The NIH has created something called the Long COVID Research Study. And this Long COVID Research Study is called the RECOVER Cohort. And the RECOVER Cohort is a national study in the United States in which patients in multiple cities are going to be enrolled. And this is going to be a way to understand and to understand the pathophysiology, to understand the disease. But more importantly, it's going to be also a way to really know what the treatments are, because these patients are going to be enrolled in clinical trials, and we're going to be able to understand what causes COVID, what causes long COVID, and what are the best therapies for these patients. So in conclusion, post-acute sequelae of COVID is a heterogeneous condition with likely a multi-factorial pathogenesis. I don't think we can say it's one individual's, it's one thing. But in these patients, we see signs of deconditioning. We see preload insufficiency. We see changes in exercise physiology. We see reduced peripheral oxygen extraction. And the severity of initial COVID is not associated with differences in exercise capacity. The recovery time is variable. And it's going to take a multidisciplinary approach to manage these patients. And I really believe that having a multidisciplinary approach is what is needed to really understand and manage these patients and do the clinical trials that are necessary. I think we're going to see a large number of individuals that are going to experience long-term sequelae of COVID. And I think this is going to be a major challenge for those of us as clinicians trying to understand what is the issue, what is wrong with these patients, and what kinds of things do we need to do to manage to support these patients. And I think rehabilitation is going to be critically important as we try to get these people back to a more normal life. There are many outpatient post-COVID clinics opening in many localities where large outbreaks have occurred. And these clinics are going to be critically important to managing these patients and to understanding these patients and to help us really understand the pathogenesis of the disease. The RECOVER cohort funded by the NIH through NHLBI, I think is going to be critically important to understand the syndrome and to really create an integrated, thoughtfully integrated research agenda. I'm very pleased to see that also patients are part of this agenda and are really driving the research to better understand this disease and to then take us to therapeutic interventions. because this cohort is really going to be the opportunity to efficiently and systematically conduct the studies of therapeutic interventions to mitigate the adverse physical and mental effects of that are affecting hundreds, if not, thousands, if not millions of people who have recovered from COVID. And this is going to be a major challenge for all of us. This is going to be really a big problem that we all need to get involved with, because long COVID is not going to go away. Numbers are very high. And I think this is going to be a very important challenge, scientific challenge and clinical challenge over the ensuing years. And with that, I'll end and happy to hear your questions.